Great, thank you, Tanya. So let me just introduce our speakers. Dr. Feely is a board-certified internist who decided to pursue medicine as a second career after being a researcher at Regeneron Pharmaceuticals for many years. He graduated from Ohio State University School of Medicine and continued on to complete his residency at Northwell Medical Center in New York. He has since decided to remain at his home institution to continue his training as an obesity medicine fellow. Dr. Mittal is a board-certified internist and American Board of Obesity Medicine diplomate. She graduated from UT Health Science Center at San Antonio and completed her residency at McGaw Memorial Hospital of Northwestern University in Chicago. Dr. Mittal is the founder and director of the Radiant Health Weight and Wellness Clinic in Frisco, Texas, and is the vice president of the Dallas Obesity Society. So thank you both for being here, and thank you both for presenting the evidence behind exercise. Dr. Feely, I will let you start first, and I'll let you share your screen, okay? Oh, and if anyone has any questions, feel free to throw it in the chat, or you can unmute yourself and open it up and talk. There will be some time at the very end for discussion as well.
All right, so as you just heard, I'm Dr. Feely. I have an internal medicine background. I'm currently a PGY5, starting my second year of a 2-year fellowship program in obesity medicine and general internal medicine at Northwell Health and the Donald LaBarba Zucker School of Medicine at Hofstra. And today I just wanted to talk a bit about various exercise modalities and how to incorporate them when making exercise recommendations. So let's start with talking a little bit about the multiple components of physical fitness. I tend to focus the most on cardiorespiratory fitness, but all the components are important in obese patients. Musculoskeletal fitness is essential for daily activities that may be as simple as getting out of a chair, flexibility to perform tasks that require maneuvering. Balance is important to prevent falls and injuries, and specific biomechanical challenges are posed to obese patients associated with changes in their center of mass. And then speed as well, which allows for intensity of exercise, as well as the ability to react to the environment quickly, which can also be impaired in the obese. So we'll look at various forms of exercise training, which have specific and overlapping benefits to the components of physical fitness. So starting with endurance training, so focuses on cardiorespiratory fitness, involves whole body, large muscle group movements in a rhythmic manner for a sustained period of time. It's walking, jogging, cycling, swimming. I'm sure most of you are familiar with this. And resistance training as well mostly focuses on musculoskeletal fitness, involves weights, bands, body weight exercises, things like that. Dynamic flexibility training focuses a little more on balance and flexibility, may have some mild effects on muscular endurance and cardiorespiratory system. These are things like yoga, Pilates, Tai Chi. Then you have things like high intensity interval training that alternates short periods of maximal effort with less intense recovery periods in a sustained aerobic workout. Improves cardiorespiratory fitness and may also improve musculoskeletal fitness. This can be done in the form of the same exercises that we talked about in endurance training, just in alternating intensities. Can also otherwise be done using resistance exercises as some of your bursts of energy if they involve large muscle groups. So there's a lot of ways to do it. And mixed strength and aerobic training, which is like circuit training, is kind of similar. It affects both cardiorespiratory and musculoskeletal fitness, and basically involves working different muscle groups one after another. So you're constantly working, getting a cardio workout, but also working your muscles. So there's a lot of programs that utilize this: Body Pump, CrossFit, Orange Theory, things like that. So I just want to talk a little bit about the advantages of different forms. So aerobic training is probably the most well studied and all familiar. Is benefits of weight loss, decreased visceral adiposity, decreased cardiovascular risks, and decreased fatty liver, improved insulin resistance, improvements in cognitive function and mood. Resistance training shows benefits to some degree in most of these things, maybe a lesser degree, and there's a little bit less research on some of them. But more the focus of resistance training is improved functionality and an increase in bone mineral density. Dynamic flexibility training improves mobility and functional capacity, can reduce falls. A meta-analysis of 30 randomized controlled trials found no significant effects, though, on weight, BMI, body fat percentage, waist circumference with yoga compared to usual care. However, I found some other studies showing that with men with metabolic syndrome, that they had did a year of yoga and had a more favorable change in their waist circumference and ghrelin levels. So there may be long-term benefits if it's studied more. And things like Tai Chi, which showed similar but slightly less results to walking in terms of weight loss and circumference and things like that. High intensity interval training and circuit training offer some similar benefits in that they offer a combination of benefits you often see in endurance training and resistance training, but in a more time efficient manner without doing double the volume. There's some evidence that high intensity interval training may increase cardiorespiratory fitness, specifically a bit more quickly than your standard steady state aerobic training. So I wanted to focus on comparing benefits related to different medical conditions of resistance versus aerobic exercise, primarily because the dynamic balance and flexibility didn't really have as much of a metabolic effect, even though there were benefits, and HIIT and circuit training are kind of combinations of these. So I thought it would make most sense to compare these two. So in terms of weight loss, most of the, say the strongest data for weight loss and decrease in BMI really came for aerobic exercise. The data was a bit more mixed in resistance training. May slightly favored mild weight loss, but there is favorable changes in body composition. Some of the fat loss may be compensated by some muscle gain. So these metrics may not be the best for comparing them, but generally speaking, there seems to be more fat loss as well with aerobic exercise. Something that's pretty interesting was changes in skeletal muscle efficiency. So routine dynamic training of the same muscles may promote biomechanical efficiency. So especially with aerobic exercise over time, you tended to see more efficiency and less caloric burn for the same work. But resistance training actually reduces skeletal muscle work efficiency. Still working on understanding that, but it has to do with the kind of a more molecular level with the actin, myosin, and everything. But so this may also support the benefit of combined training because you're getting more calorie burn with aerobic exercise, and you can counter the efficiency in that process by doing resistance exercise. In terms of calorie expenditure, so as I said, you really see more during the exercise with aerobic activity. Well, I did find a study showing with participants who did resistance training actually had more vigorous activity, non-exercise activity on non-training days than the aerobic group. So they may be getting activity elsewhere. Also, muscle is metabolic, but so building muscle may burn more calories. However, I think it's worth noting that this effect may get more credit sometimes than it really deserves. One for each pound of muscle at rest burns about 6 calories per day. So if you put on 10 pounds of muscle, you're looking at 60 calories extra burned a day. And since fat, let's say you lost 10 pounds of fat, then that's about 2 kilocalories per pound per day. So It's really just an additional 40 calories a day by replacing 10 pounds of muscle with 10 pounds of fat at rest. So that effect may not be as great as our impression sometimes, but at the same time, that may not account for increased calories burned from increased workload during your exercise because you have more muscle, or maybe if you have extra muscle weight you're carrying around, maybe other factors there. But at least the resting metabolic rate of the muscle has some effect, but not huge. For insulin resistance, visceral fat, and fatty liver results are kind of the same. The best groups were always the ones that combined resistance training and aerobic training, but aerobic training seems to be fairly close to the combined group, and resistance training didn't. It was variable based on studies, but resistance training didn't seem to have as big an effect on its own. Next, cardiovascular benefits for aerobic exercise are fairly well established. You might see lesser degree of similar benefits in resistance training. A lot of people are under the impression that resistance training may increase blood pressure. There seems to be a clinically insignificant increase in blood pressure during the actual resistance training, meaning you're not likely to put a hypertensive patient into hypertensive urgency or something with the weightlifting. You might see a very slight increase, but long-term effects actually do favor blood pressure reduction, even though maybe not quite as much as cardiovascular exercise. I thought obstructive sleep apnea was really interesting. There's not a lot of studies comparing resistance and aerobic exercise, although there are studies for each showing improvement. The amount of improvement in the obstructive sleep apnea seemed to be disproportionate to the weight loss, meaning that exercise actually had fairly significant benefits for obstructive sleep apnea that were not just attributed to the weight loss and the loss of fat mass in that area. There was a meta-analysis of 5 studies that showed a reduction in the apnea-hypopnea index of the exercise groups of 6.27, which was a 25 to 30% reduction in apnea events. And these groups showed an insignificant weight loss to the non-exercise groups. And that reduction is equivalent to about what would be expected from 10% body weight loss from diet. So basically, with an insignificant weight loss from exercise, they got the same benefit in their reduction in hypopnea episodes as you would expect from 10% body weight loss. So I thought that was pretty significant. There are a lot of theories as to that. It's not fully known why, but there's an increase in slow wave sleep when people who exercise, and slow wave sleep is associated with fewer apneic episodes. There's some theories about that it may increase the tone of the genioglossus muscle, and so there's less collapse. So it's interesting, but it's not fully known why. But it's not just the weight loss, which of course is also important. So osteoarthritis. So they sort of play a different role. Weight loss is really important for 2 reasons in osteoarthritis. One, just physical impact, decreasing mechanical load, but also the fat mass secretes adipokines like leptin and adiponectin that are directly involved in the inflammatory component of osteoarthritis and cartilage damage. So, so reducing the fat mass is actually really important in controlling osteoarthritis for that reason as well. Resistance training played more of a role in terms of strengthening the joints and improving function and decreasing pain. Depression, so weak, but some evidence for improvement for both types. There's definitely a lot more studies in aerobic exercise. And bone density changes. So really the best are the weight-bearing resistance exercises like deadlift, squats, military press, but high-impact exercises of aerobic activity like running, jumping, stair climbing may be helpful as well. Things like swimming and biking actually showed not only no gain in bone mineral density, but no prevention of loss either. So it had to be some kind of impact or weight bearing. So then just to briefly touch on, when you're assessing a patient, trying to think about what you want to tell them to do for activity. Does this patient need clearance? We don't have to go through this whole algorithm, but it's by the American College of Sports Medicine for who should be cleared. It's kind of a summary here. The main points is really you want to look at, have they been active, or is this new activity? Do they have any symptoms or signs of cardiovascular disease? Do they have a medical history, cardiac, metabolic, or renal disease? I think the most important thing right off the bat, do they have symptoms or signs, angina, orthopnea, palpitations, syncope? Then they need clearance. They need to be evaluated. That's really the most important thing. But if someone has a medical history of cardiac, metabolic, or renal disease, and are asymptomatic, and they have been previously active, they don't need clearance unless they want to do something really vigorous. But if they have not been previously active, you may want to look further. Just to note, clearance does not mean necessarily testing. It just means the medical provider has to further just kind of look into it. It doesn't mean order a stress test. So just briefly, when assessing intensity of exercise and functional capacity, so we can assign the intensity of exercises as light, moderate, or mediate, or vigorous by the number of metabolic equivalents. One metabolic equivalent is defined as the amount of oxygen consumed for energy at rest. So if you're consuming 3 times that amount of oxygen in the activity, then that would be 3 METs. So light activity is less than 3 METs. That's like cooking or household chores. Moderate is 3 to 6 METs. Brisk walking, raking. Vigorous is more like your exercise. You think of jogging, running, going upstairs, groceries, shoveling snow. You can also just use a 2-question test. If they answer yes to either of these questions, then they are probably low risk. They're able to do something over 5 METs. So really just, can you walk approximately 10 minutes at about 3 miles an hour without experiencing limiting symptoms? Or can you climb 2 standard flights of stairs without stopping because of limiting symptoms? So do they need exercise stress testing? Both the USPSTF and the American Heart Association agree there's no value for screening with an exercise test in low-risk asymptomatic adults. They actually say if it's just a pre-participation assessment for structured exercise, high-risk subjects have insufficient evidence for or against exercise stress tests. So you're really using your clinical judgment. There's someone you think needs one anyway. So there's some room there for your clinical judgment. Other things just to assess, you want to make sure from a musculoskeletal point of view, it's safe. Do they have injuries, things like that. For really obese patients, lower impact activities are usually safer. So I would recommend walking slower on a modest incline as opposed to walking faster on a level grade. With diabetes, there's a few things to consider. You want to avoid exercise in someone obviously doing ketosis, or if they have a blood sugar over 250. So believe it or not, even if they're hyperglycemic and they exercise, it may actually worsen the hyperglycemia because you're increasing your catecholamines, your cortisol, your glucagon, all mobilizing sugar from the liver to the blood. And if there's not enough insulin, there's usually less insulin secreted as well. And then if they're insulin resistant, then it can just result in more hyperglycemia. The reasons for hypoglycemia are a little more obvious. They're under 100. They should be having something with some carbohydrates beforehand and repeat testing during exercise. And there's a risk for late hypoglycemia 4 to 8 hours after the exercise because blood sugars are depleting the depleted glycogen stores. Just worth noting, they have proliferative retinopathy and a recent or active retinal bleed, avoid vigorous activity, and neuropathy, avoid traumatic weight-bearing exercises, and recommend well-fitting protective footwear. Other things to assess after clearance: readiness and motivation, any barriers they have, whether it's safety of their environment, accessibility to a gym or other resources, what their time, what they have in terms of time commitments, and just kind of come to an agreement with the patient, and think about any type of equipment needs or program modifications based on your assessment. Attrition rates are really high among people who have been sedentary most of their life and then start a new exercise program. And this especially is true in the first 5 to 10 weeks during the initial conditioning phase. So it's a good time to keep an eye on them, to keep in contact with them, have them come to the office for a few visits. Sometimes just even emphasizing the value of small increases in physical activity may increase adherence. So to tie it all together, there's various modalities of exercise that can provide specific and overlapping benefits. Weight loss and most parameters of cardiometabolic fitness are most improved or studied in aerobic training. Resistance training improves body composition and is important to functional status of the obese patient, and also has similar benefits seen with aerobic training, even if they're more modest. The combination of the two seems to yield the greatest benefit, and sometimes you can get this through high intensity interval training or circuit training with less time investment for your busy patients. And you want to assess the appropriateness of an exercise regimen that will yield the greatest benefit and lowest risk in the context of existing medical conditions and functional status, and assess like social limitations and provide support to keep them going. And that is it.
Great, thanks so much, Dr. Feely. That was a very comprehensive exercise presentation. Thank you so much. I'll just make my first quick comment is I think it's really wonderful that you focused on all of the health benefits as opposed to just weight loss. Obviously, as obesity medicine practitioners, our goal is not just to reduce the weight number, but of course, address the comorbidities that come along with that. And that means, you know, your primary, secondary, tertiary prevention, preventing patients from developing the disease or even exacerbating the disease. We do have a couple of questions from the group chat. I don't know if, let's see, Reese Oshner would be willing to share your question.
Sure. Hi.
Hi.
I'm Reese. I'm here in Texas. I was just curious if you had any data about appetite changes with aerobic versus resistance training, you know, contributing to higher calorie intake.
I actually didn't find that or look for that. That's actually a good question. I'm curious to look into that. I do see that there was a response. I don't know if it's the same, but there may be some transient anorexia associated with high intensity exercise, 30 to 60 minutes. But yeah, yes, I actually didn't find any data on that while I was doing research.
I've actually seen a mixture of results on that in terms of exercise and change in appetite, but I don't know that it was necessarily correlated to intensity. I'm also I'm not satisfied that the change in appetite is alone why exercise sometimes fails for initial weight loss. But I would like to add to Beverly's comment that it's important that Karen, that you discussed the health benefits of the exercise, but I also think we should look at exercise as not just in terms of short-term weight loss, but in terms of the long-term physiologic benefits, right? So if we assume that insulin resistance is part of what makes it hard for our patients to sustain initial weight loss, and then long-term that adaptive thermogenesis is a piece, then clearly exercising and creating muscular inefficiency should help at least some of that.
And that's why I included that part about the year of yoga having favorable ghrelin profile, just because, I mean, most of this data really is not looking at things beyond a year. And there may be things that we'd see differently if we were looking at a longer term picture.
Do you know, do you remember in that study if they remained the same weight throughout that year?
I believe for that one that the only parameter that changed was there was a decrease in waist circumference, a significant decrease in waist circumference, but not other metabolic parameters.
Interesting. All right, so just in the interest of time, I'd like to go ahead and invite Dr. Midal to do her presentation. Thank you, Dr. Feely.
Thank you.
And we'll have time at the end for some more questions too. You're also muted.
Okay, now y'all can hear me. I'm gonna go ahead and share my screen. Let me know if you guys can see it.
Looks good.
Okay, awesome. So I'm Richa Mithal, and I'm based in Frisco, which is a suburb of Dallas. And thank you, Dr. Chang, for having me collaborate with you guys. So I'm going to be talking more from a clinical perspective today on impacts on weight of physical activity. All right, I have no disclosures. So I'm going to start with a case. So this is a 42-year-old woman with type 2 diabetes, hypertension, hyperlipidemia, BMI of 35. I'm sure we're all familiar with people like that. This patient's been trying different diets with various success and has been having a hard time maintaining the weight loss. Nutrition-wise, trying to avoid added sugars and mostly does avoid successfully, sticking to a low-carb approach, and doesn't really like exercise very much. Her watch does remind her to move around, and she thinks she gets about 5,000 steps a day on her tracker. Just in the interest of kind of completion of the workup, her sleep is decent, 7 hours. There is a history of snoring, has never had a formal testing for sleep apnea. And social history, she's an IT professional, so she sits most of the day at her computer. So as we know, as clinicians who take care of individuals with obesity, you know, there's multiple factors, right, that contribute to obesity. And in order to thoroughly treat a patient, we have to be looking at it from a very comprehensive, holistic view. And today we're honing in on physical activity, so I have that highlighted. But even in the patient's presentation here that I just gave you, you're thinking about all these things, right? So we're gonna hone in on physical activity. So today I want to cover for you how we can counsel this patient on getting started with an exercise program. What are the general guidelines? How can we help her set goals just from a practical standpoint? Are there cardiovascular benefits, which Dr. Feely just touched on a little bit? Can exercise help her with her weight loss efforts? And how does it affect her ability to prevent weight regain? So this is basically analysis of data from the National Health, I always forget the name of this, National Health and Nutrition Assessment Examination Survey, looking at about 2,000 patients. And basically the walkaway point of this was that time spent in activities like sleep, sedentary behavior, light versus moderate physical activity is significantly associated with the parameters of BMI, waist circumference, triglycerides, insulin sensitivity, blood pressure. And the reason why I put this here is for us to be able to start empowering our patients with the idea that, you know, your decisions every day and how you move, etc., have an impact on your health. Like we were just saying, it's not just about weight. So what are the recommendations? The WHO and the US guidelines are either 150 minutes of moderate intensity aerobic physical activity or 75 minutes of vigorous intensity per week. And also doing muscle resistance training at least 2 days a week. Interestingly enough, at least from the data that I saw, we think that probably about 60% or more of our population does not get this level of activity. And I'll admit that I don't always either every week. So when we're counseling our patient today, she's going to ask us, well, what does that look like? So here's a chart that I got from the WHO, and it basically on the left shows us activities that would give you a moderate intensity workout, which like Dr. Feely just mentioned, 3 to 6 METs. And those are going to be things like brisk walking, dancing. I don't know about gardening. I guess it has to be pretty intense. And then vigorous activity on the right is going to be more intense, like running, jogging, walking uphill, fast cycling. And so these are some examples of things that people can do. I also wanted to point out that they have this on the WHO site, and it's really interesting, is that even just small changes, you know, people might think that, oh, well, maybe the moderate intensity isn't going to really do as much for me. But comparing to a person who's seated, who's not doing anything, they're going to burn more calories with a moderate activity, up to 3 to 6 times more, versus the vigorous activity is going to be more than 6 times. So what are the cardiovascular benefits? So the basic guidelines, and this is from a paper that was a meta-analysis looking at many studies that are observational, that came out in Circulation in 2011. And this was comparing basic guidelines versus advanced guidelines. And what are the impacts, the dose-responsive impacts on cardiovascular risk? So for the people who did the moderate amount, they saw a 14% lower coronary heart disease risk, relative risk, compared to people who did not have any leisure activity, physical activity. The advanced guidelines, which were 300 minutes per week, had a 20% lower risk compared to people who had inactivity. And interestingly, even the people who had physical activity that was at the levels below what are recommended did have a significantly lower risk. And they saw that the association was stronger amongst women than it was in men. So for our patient today, we've established to her what the guidelines are, we've established what activities she could do, but now to translate that into action, and I use this in my practice, is using some goal setting techniques. So we want to be specific. An example of that would be for her to say, I will walk more. It needs to be measurable. So we're going to set a goal, 30 minutes, 5 days a week. We're going to make it attainable. So maybe she's going to split that up and she's going to do 15 minutes in the morning and 15 minutes in the evening. It needs to be relevant. What does this action do for her? And so I want her to specify this will help to improve my blood sugar and my weight. And then time related. We're not looking to accomplish this goal over 6 months. We want to put a time limit on it. So I will attain this goal over the next 4 weeks. So what about muscle loss with weight loss? And the previous speaker touched on this a little bit. Obesity is associated with poor muscle quality. So they, you know, if you do a body composition analysis, they might have more muscle mass, but that muscle itself is of poorer quality and has more lipid deposition. Weight loss is associated with a loss of lean body mass. So there's an increased risk of that sarcopenia because now they're not only losing muscle, but what they have is of impaired quality and poor muscle function. With total weight loss, fat-free mass loss might be about 20 to 30%. And if there is a combination of the calorie restriction over time and an inadequate protein intake, this augments the loss of lean body mass. So regular physical activity, especially muscle resistance training, is recommended for people who have obesity, who are undergoing weight loss in order to limit the loss of muscle mass. So what are the guidelines from the American College of Sports Medicine for prevention of weight regain? So interestingly enough, the maintenance and improving health is going to be your 150 minutes a week. To actually promote significant weight loss, you'd have to work out 225 to 420 minutes a week, which is quite a bit. And then prevention of weight regain after weight loss is 200 to 300 minutes. So clearly this needs to be part of the strategy when we're looking at weight maintenance, right? So for our patients who are, in the acute weight loss phase, we're working with them on all those different aspects. And maybe cardiovascular activity is going to be more of the target there. But we really want to make sure that we're building those habits, using our SMART goals to get to this level when they're in weight maintenance or when they hit a weight loss plateau. So the National Weight Control Registry has been following patients and who have lost weight, and over 10 years, this was predominantly women, who lost 30 kilos and were able to maintain that weight loss over 1 year. 90% of them were exercising for 1 hour a day. That's a lot. So let's touch a little bit on the adaptations that occur with weight loss and that actually promote weight regain, and then how exercise can be of benefit. So after weight loss, there's many things that happen. There's an increased hunger. I think we touched on this a little bit in the last talk. Decreased satiety, so we have increased levels of ghrelin, lower levels of leptin, decreased resting energy expenditure, decreased metabolic mass, and we're stimulating that NPY, agouti-related peptide pathway in the hypothalamus that is going to now drive weight regain. So what exercise can do, and this is from an article from 2018, I have the reference down there for you, is that we can actually work towards preserving the metabolic mass, which can help to maintain the resting energy expenditure. And I'm also going to touch base on how that can help with NEAT and increasing that. So, burning more energy at rest, even when we're not exercising. We're also going to have an effect of the exercise to decrease hunger and increase satiety. We have improved insulin sensitivity, which is going to affect the patients who have the insulin resistance, playing a role in their weight regain. So there's a lot of benefits there with exercise, again, during the weight regain time period that we want to help our patients with. So as far as just to round out what the total energy expenditure looks like, it is made up of resting energy expenditure, which a lot of people also call the basal metabolic rate, which you're just burning at rest to live and breathe. You have the thermic effect of meals, which is what you expend to process the food you're eating. And then you have the energy expenditure from physical activity. And that varies a lot from person to person. And it is made up of two components. So one is the formal exercise, which we've talked a lot about today. And then it's also made up of NEAT, which is your non-exercise, what is the A? It'll come back to me, thermogenesis. So that is going to be basically the calories you burn during physical activity that's not formal physical activity. So that is not only extra caloric expenditure, but there are studies that show that people who have increased levels of NEAT have a reduced occurrence of metabolic syndrome and cardiovascular events, as well as all-cause mortality. So again, kind of going beyond weight as far as what the health benefit is. Also, NEAT, higher levels of NEAT are correlated with higher levels of a neuromodulator in the hypothalamus called orexin, and low levels are associated with obesity. So how does that translate to our patients clinically? So again, when they're formulating their exercise plan and we're giving them that prescription in the office, we've touched base on how we would increase formal activity. And what we can also do is talk to them about how to increase their NEAT. And so that's going to be things like, well, when they were driving to work or the grocery store, maybe they were parking further away. Of course, we're not doing that right now. Taking the stairs, maybe working upstairs and knowing that you're going to go up and down the stairs a few times a day. I urge all my patients to stand while they're working, especially right now with the pandemic. We're all sitting around on our computers and we're not really moving around very much. So it's really important to try to stand as much as possible. You know, a lot of people like to use the activity trackers. Maybe they set reminders on there to get up and move every hour. So that's, you know, kind of what feeds into when I talk to my patients about just being mindful. You know, could we be having this conversation while we were standing? If so, stand up. So this is another study that I thought was interesting. It was looking at a group of 140 premenopausal women who were sedentary at baseline. Their BMIs were over 27, less than 30. This was done at the University of Alabama. And they basically took the women, divided them into 3 groups. So they had either aerobic activity for 40 minutes a day, 3 times a week, or muscle resistance training 3 times a week, or no physical activity. And they looked at the measurements of the total energy expenditure, resting energy expenditure, and NEAT, and compared the groups. And basically, over this time period, and it's slipping my mind how long the study was. I will get back to you on that. But at the end of the study period, they found that the total energy expenditure, resting energy expenditure, and NEAT were all decreased for the no exercise group. So clearly, that's not good. And with the exercise group, both of the groups, they had a decrease in their resting energy expenditure, which, you know, we kind of expect, right? With the weight loss, where we expect that people's resting energy expenditure goes down. But guess what? Their total energy expenditure was higher and their NEAT was higher. So they were just in a better position to be able to maintain their weight loss. And these patients had all lost the same amount of weight, 25 pounds, and they were on a calorie restriction of 800 calories a day prior to the study. So in summary, how can we help our patients? We need to be realistic. We need to be supportive. We need to educate them on what the guidelines are and the recommendations, and then how they can practically fit exercise into their lives, especially for, well, everyone's just really busy, right? Life takes over. Our patients have been struggling with things. Maybe they haven't really had exercise be a part of their life. And so it's on us to educate them about the benefits as well as how they can do so, and empower them with the tools on how they can practically get moving. And so this is my information on how to stay connected. I'm on multiple social media platforms and I have a blog, and you can always email me, and I love to collaborate and connect. So thank you.
Thank you, Dr. Middle. So actually, my question is actually for everyone. I don't know if you can share your slide deck again and just go to that very first case slide.
Sure.
What would any of you recommend to this example patient for physical activity?
Sorry, I'm just going to go back here. Okay.
I've had, I'm actually from Houston, so I'm excited to be joining. Thank you guys for sharing the link. This is Anisha Gupta. I have had people get standing desks, so that way they are working from their desk while standing. I remind them that we want you to move every 30 to 60 minutes. I know it's 90, but I tell them every 30 to 60 minutes. So I say, if you're on a phone call where you're not really presenting, you can do a couple of squats every couple of minutes, or walk around during that meeting. You can't walk around pre-COVID during meetings, so that's the beauty of having online visits. And then I really like the step trackers because people like to finish their circles. So try to get them to maybe get to like 5,500 or 6,000 steps, and then try to slowly increase her eventually so that she's really pushing herself, but with small increments. And I think, you know, those are things that she can start with, and then eventually you add to it, but just, you know, trying to get things that work within her schedule already.
So I'll just add that it's always challenging when you're working with the patient who tells you up front, hey, I just really hate exercise. I already know that you're going to beat me over the head and tell me that I need to exercise, and I know I should exercise, but, you know, 5 different reasons why they can't exercise today. So instead of really fighting them on this, then just ask them, hey, what do you do already? And also, what did you used to like to do? You'd be really surprised at what people will come up with. So I think one of my more surprising stories was a patient that had been trying to get to exercise just to walk more. She thought this idea was terrible, but on her own, she decided that she was going to hula hoop. She and a neighbor of hers, they get together every day in the afternoon and they do like 15 minutes of hula hooping. Great, you know, way more activity than you were doing before, but at least gets them thinking about what do I like, and then just kind of go from there. The other thing I like to tell patients is anything is more than where you are right now. So that means if you can do 5 minutes, that's greater than 0. 10 is greater than 5. 15 is greater than 10. And that's how you start a program, and that's how you can keep building. I think that's much safer also with patients who haven't done a lot of physical activity, and we're talking about, you know, concerns about cardiovascular clearance. If they build up slowly on their own, you really don't have to worry too much about adverse events and effects. So that's kind of my 2 cents on this. And thank you, Risha, for the presentation. That was awesome.
Yes, thanks for the presentation. I probably take a little bit different take than most people here. So I get really aggressive with exercise, and that doesn't mean that everyone has to go into high intensity, but I get aggressive in my language. So one thing that I think is worth noting is that depends on which study you look at, but anywhere from 80 to 99% of people will regain weight within 3 years if they haven't had surgery. So I like using those numbers with patients, and I try to explain to them, now if we go to a National Weight Control Registry and we see that 90% of people are exercising an hour a day, that means statistically it's almost impossible that you're going to keep weight off if you don't long-term become an exerciser. That doesn't have to be in the gym and so forth. So yes, all the stuff you guys are talking about, I definitely like to get involved in, like not torturing someone into doing an exercise they don't want to do, but really to set the stage of, like, you know, don't waste your time and not aim to be able to keep the weight off long-term. That said, been doing this for a while, so many patients that have lost over 100 pounds, and almost all of those patients that have lost over 100 pounds that kept it off long-term became exercise fanatics. Yet some of them, it took 2 years to get them to really formally exercise. They would start with a little walking, and it was an excuse, like one after another. And as the weight kept coming off, they really got into the exercise, and they realized that that's really part. And some people think that my patients are obsessed with some of this lifestyle and exercise stuff, but really, if you look statistically, how many of your patients that have lost 75, 80, 100 pounds have done it by exercise, by walking 15 minutes a day? Like, the reality is that's not going to be a sustainable long-term treatment. So they can do that in the beginning, but I always want to keep every conversation we have with them is going to say, okay, well, what's going on with the physical activity now? What can we do to help you, and so forth?
Oh, I think it depends a little bit on the patient, though. You know, I have a patient who's maintained weight loss for many years of 80 pounds or so, but she went from 0 exercise. I mean, she was basically dependent on a walker and couldn't even go up, like walk 3 steps or so. And now, you know, she uses a cane and she ambulates and she's able to walk steps a little bit. So she's not doing an hour of intense exercise, but it's sort of relative. Like, she's certainly doing more than she used to do. And, you know, I don't want to discourage some people and say, you know, you have to do this crazy amount of exercise. So I know what you're saying, but I think it also has to be individualized a little bit.
Oh yeah, I agree, and something that we often do with a patient like that is that we start them in physical therapy, or some of my other patients in pulmonary or cardiac rehab, really depending on the people with very poor functional capacity.
Yeah, definitely.
This is Sandra Christensen from Seattle, and I want to add to what's been said, which has been excellent. You definitely want to individualize, and you want to meet people where they are and get them moving. You know, we know the law of inertia is that an object at rest wants to remain at rest. Object in motion wants to stay in motion. Takes less energy to get it going. So anything you can do to get people to take one more step is good. And I really like the fitness trackers. I find I'm not a gadget person, and even for others that aren't, they really love collecting the data and then competing with themselves. So I get a baseline of how many steps they're getting in a week. We look at the range, and some will get, you know, 2,500 to 5,200. And so we gradually increase the minimum number of steps. So, and I usually only do that in increments of 500 at the most. Like over a 2-week period, can you make, you know, if you're getting 2,800, can you get 3,300 every day, and or 6 days a week? And that seems to get people moving. And once they do, they can move into what Jamie's talking about, where they get more. And it's super important for weight maintenance. But as has been said, some people can really accomplish a lot without any activity. So it's interesting to observe it, and it's very humbling for sure. So thank you for your excellent presentations, both of you, and I really like your approach.
Thanks.
Hi. If I could just add one other thing about exercise. My name is Stephanie Ophelia Peck, and I work for Northwell. I run the Childhood Obesity Program. One of the things that I think is important, and this is not just a focus of children, I used to work with adults for a large part of my career, is understanding that when people have a lot of weight to lose, there's a lot of barriers in terms of like skin chafing, embarrassment, not being able to physically do the exercise. So really understanding where the patient is coming from, I think is very helpful, and having that sort of compassion that you understand that it is difficult to start the exercise, but having resources for them that can gently get them into exercise, I think is very important. You know, I'll start even some of my kids with chair exercises, and there are some decent videos out there doing chair exercises, so that you take a patient where they are and you work with them at that starting point, because the idea of doing something more strenuous sometimes is so hard to even fathom that they give up. They put themselves in a place where they say, I can't do that, and they don't even try. And then the activity trackers are wonderful, I think, for adults and for children, because they do have reminders. I know my Fitbit buzzes when I sit too much doing telehealth, and I think it's awesome. But I show people how to use the visual on their phone screen, and they see how many steps they can get on certain days, and they're like, wow, I only got 200 steps on a Sunday when I sat around, and look how many steps I got while I was walking.
This is Sandra Christensen. I wanted to add one thing I forgot to mention, which is I have a fair number of patients who work for Amazon, Microsoft, and tech companies, and do other things where they're all working at home now. And a few of them have purchased treadmill desks. And I have patients that I've recommended that for before, but more and more of them are doing it, and they're really getting the steps in because they're on so many meetings all day long. And they're changing the culture of their Zoom meetings, because they're starting to be the one that just walks slowly during the meeting, and then other people are following suit. So I often talk to my patients about being a culture changer and being a leader that way.
Great. Any other final comments as we wrap up? All right. Well, thank you again, Dr. Feely and Dr. Middle. Those were both very wonderful, informative presentations, and I hope that we all kind of got what we needed out of them. And I think that everyone will, as everyone said, tailor those recommendations to individuals when it comes to physical activity and their baselines. So thank you, everyone, for coming. Again, this presentation will be available online to rewatch. I think some people asked about the slide decks. They might be, but we'll have to, that's to be determined. We'll see. Okay. And just to remind everyone, again, we're representing Tri-State Obesity Society. Dr. Vinton here from Dallas Obesity Society. If you are interested in more local, regional activities, just reach out to one of us, pending reopenings and such. And thank you again for everyone's participation.